So good afternoon, everybody. My name is Dr. Sikaneta, Tabo Sikaneta. I'm one of the nephrologists at the Scarborough Hospital, and it's my challenge and honor to try and talk about this topic, a very important topic, I believe, chronic kidney disease and poverty. Present some information both about this link worldwide and what happens here on the ground in Scarborough. I'll start with the definition. So CKD, as most of us know, being working at a very kidney-heavy hospital, is a sustained, more than 3 months, reduction in GFR, less than 60, and or an increase in proteinuria rates, so a urine ACR of more than 3. These thresholds were defined because once you exceed them, the associated rates of death, cardiovascular disease, infection, depression, hospitalization, and of course, end-stage renal disease all go up quite significantly. The risks for the end-stage renal disease are, both of these are important, and it shows on the slide on the right why. The graphic on the left, the GFR can be normal, let's say higher than 60, but if you have a GFR or a proteinuria rate that's of over 30 milligrams per millimole, then you are at high risk of progression to end-stage renal disease. So both are very important for this definition. And using that definition, the global prevalence of CKD is about 13.4%. So it's very common, surprisingly common. And if you look just at reduced eGFR alone, still pretty common, 10.6%. And of those that progress to ESRD, about 3 million are currently receiving renal replacement therapy worldwide. And for those that cannot receive renal replacement therapy, choose not to, but the majority cannot, 3 to 7 million of them die every year because they don't have access to renal replacement therapy. So CKD currently sits at spot number 17 of all causes of death, but it's rising. It's the third fastest growing cause of death, the leading cause of death in terms of non-communicable diseases. And so it's projected to be the fifth leading cause of premature death by 2040. It's the only non-communicable disease that's increasing according to age-adjusted mortality rates. So compared with the other big hitters, cancer, heart disease, stroke, diabetes, you can see where CKD fits now, both 2016 and projected to 2040. The rate of rise is what's remarkable. The heart disease rates in 2040 are going to be lower than they are now. Same for stroke. They're going to be about the same for the chronic lung disease category. They're rising for diabetes, but they're rising more so for CKD. By 2040, it's predicted that chronic kidney disease will kill more people than diabetes. Now, the distribution of the traditional and non-traditional risk factors for CKD are such that the rates of rise are going to be higher in low and middle income countries. So in the overlap here, you see risk factors for non-communicable diseases recognized by the WHO, which overlap with those that predict or are risk factors for CKD, diabetes, prediabetes, smoking, obesity, aging, hypertension. And there's some other factors that are more common in lower or middle income countries than in first world countries or developed countries. And they are the effects of environmental change, disproportionate effects for countries, nephrotoxins, obstructive uropathy, certain of the genetic and glomerular diseases, infectious diseases are more common in those parts of the world. And poverty and malnutrition, which have effects directly and indirectly on kidney disease, are more common. So for these reasons, kidney disease is becoming more of a problem in low and middle income countries. To look at hypertension as a specific example, a leading cause of kidney disease, the rates of rise of hypertension are shooting up in India, as India has rapidly gone into the middle income country category, as has China over the last few decades. And along with that, the rates of hypertension have shot up. Sub-Saharan Africa, they're projected to almost double. In this case, it's not because of growing affluence, but the rates have almost doubled. And those countries that are more affluent in the far right, the rates are going up, but they're much smaller. They're nowhere close to the rates that are going up in these other countries. And the costs of CKD, once patients reach the end stage, are quite significant, both for the states, for the country states, as well as individuals. The estimated costs of dialysis are about $50,000 to $80,000 per year. And in the vast majority of cases, these costs are borne by the state. It's estimated that only 0.1 to 0.2% of the population in high-income countries have end-stage renal disease requiring dialysis, and yet they consume 2 to 4% of the healthcare dollars, including here in Canada. So disproportionate amount of healthcare dollars go to a very small number of proportion of the population, and the poorer countries can just not afford this. This slide shows the prevalence of renal replacement therapy worldwide per 100,000 people in 2023. And despite what we talked about, the risks and the likely rates of kidney disease being much higher in poorer countries, the proportion receiving renal replacement, for example, in large swaths of Africa, are less than 10 per 100,000, whereas in the US and in Canada, they're over 75 to, or sorry, over 100 to over 150 per 100,000. So there are fewer people, but among the ESRD population receiving dialysis, it does not in any way match where the disease is. This is shown here, even when you look at age-standardized prevalence of dialysis. Globally, the rates are roughly, they are 40%, 40 per 100,000. But in parts of sub-Saharan Africa, this rate is, 3, 4 in the far right. Transplant is negligible. South Asia, a huge part of the world in terms of population. Again, only about 10 per 100,000 receive dialysis, and the transplant rates are negligible. The Caribbean has more, maybe 50, but it still falls short of the rates in high-income countries like Canada. This was an interesting survey that I wanted to share with you, released in JAMA a few years ago. The International Society of Nephrology sent out a survey to key national stakeholders worldwide to find out what is the state of their kidney programs and manpower, etc. They sent out surveys to 130 countries, 125 responded, so a pretty good representation of about 93% of the world's population. And they looked, among other things, at how many nephrologists were there. What was the manpower, current manpower as of that time in terms of nephrologists? And so per million population, places like Canada and the US, Brazil, Argentina, Russia, Australia, Europe, have more than 15 nephrologists per million people. And places like Africa, most of Africa, India, parts of the Indonesia and Malaysia and the parts of the Middle East have less than 5 nephrologists per million population. So the manpower is not evenly distributed, certainly not when you consider where the needs are. And in addition, when they looked at what was the availability of serum creatinine with eGFR reporting, how available was it? It was rarely or never available in 46 to 39% of African countries. So, even just to make a diagnosis of CKD, primary care level caregivers, because there aren't any nephrologists, but those who are there on the ground, 46% rarely, 39% never had access to serum creatinine with eGFR reporting. And by the bottom set of rows, it's by income class. 41% of low-income countries rarely have the opportunity to measure creatinine. 59% never have that. That's just sobering. And in Canada, of course, part of North America, where there are two countries, it's always or it's usually available. Same for urine albumin to creatinine ratio, the other key part of measuring or diagnosing kidney disease. In Africa, 33% rarely have access to reporting. 55% never have access, not reporting, to measuring it. It cannot be measured in 55% of African countries at the level of the primary care physician. Glucose monitoring, similarly, it's skewed such that there's much less that's available in the poorer countries. 46% do not have or rarely have access to glucose monitoring, blood glucose monitoring, that is. 12% do not at all. Whereas in North America, it's going to be 100% between always and usually. Dialysis is not funded. It's already super expensive, as I mentioned, and therefore, understandably, the rates of coverage of hemodialysis, and it would be similar for PD and for transplant, are such that low-income countries rarely have publicly funded provision of dialysis. It means that if there is dialysis, it has to have some or more of the private sector pay for it. 12% in low-income countries pay out of pocket, which is remarkable considering how expensive it is. PD, which, as I'll get into a bit later, might make more sense in terms of state contributions to paying for ESRD because it tends to be cheaper, is just not available in low-income countries, wholly funded by the government. In Africa, 35% of the programs will offer PD, but it should be much higher considering that this is a more cost-effective way to treat end-stage renal disease. So I'm going to switch gears a little bit to discuss now poverty, the other half of my talk today. Absolute poverty, as defined by the World Bank, is living on less than $1 a day. That's extreme poverty. And there are 1.2 billion people worldwide who live on less than $1 a day. There are 2.7 billion individuals worldwide who meet the definition of moderate poverty. They live on less than $2 a day. And what this means in stark terms is abject starvation and homelessness. These are the people who are at high risk for starvation and homelessness. Relative poverty is defined differently. It's defined as a household or individual income that's less than 50%. In some cases, I've seen 60% of the median national income. And what that means practically is the inability to obtain the social and economic resources needed to participate in life, for example, to maintain a healthy diet, to purchase medications. I'll go into other examples, but the distribution of absolute poverty, and in this case, extreme poverty, is, as you would expect, not even across the world. Sub-Saharan Africa currently has 300, as of this figure. I think this was about 5 years ago. Oh, I'm sorry, this is about 19 years ago, or 21 years ago. This had 303 million people living in absolute poverty in Sub-Saharan Africa, 437 million in South Asia. East Asia had 214 million. The rates are not in the tens of millions in Europe or in North America. These rates are changing because South Asia and East Asia are, as I mentioned, moving. Their economies are growing and more people are moving from abject poverty to the middle class. Sub-Saharan Africa, not so much. Poverty rates in Canada, compared with other high-income countries, are unfortunately quite high. 15.5% meet the definition, not of absolute poverty, but the relative poverty, adults, that is, and 17% of children live in relative poverty. And the highest risks for poverty in general, as high as 52% in female-led households. In recent immigrants of color, I highlighted that because that would be of particular relevance to us working and living in Scarborough. Aboriginal Canadians, single adults, and people with disabilities, also of relevance to us. And these rates compare with the low of about 5% in Scandinavian countries. And when ranked with other high-income countries, Canada doesn't do so well. It's ranked only 19 out of 30 among high-income countries for adults, 21 out of 30 for families with children, 20 out of 30 for children. And these gaps, unlike the rates that are seen in Asia, are getting worse, not better. Here is, and that has to do with the income disparity. The rich are getting richer. The highest income level grew by 44% between 2011 and 1993. The lower income did grow as well, but not by as much, and therefore the gap is growing, and the same has recorded in part of Europe. So this here, I'm the first to admit, is completely outside of my wheelhouse. This is just what I'm going to share with you based on my reading, but I am by no means an expert. The causes of poverty are attributed to individual causes as well as systemic causes. The individual causes include a lack of education, the presence of physical or mental challenges which might impede someone's ability to work and take care of themselves, lack of motivation, intentional dependence on the welfare or on the social assistance system. And these are in contrast to systemic causes of poverty, which have more to do with the social fabric and the political systems in place that result in big differences in poverty between countries. In Scandinavian states, for example, there's and how these relate to the welfare state. So in the Scandinavian states, they have a social democratic approach to welfare. And what that means is that there's more universalism of social rights. The states aim to promote equality, they aim to reduce poverty, and as a result, their rates are much lower. There's much more state-funded efforts to reduce poverty. In more liberal welfare states like the US, Canada, and the UK, there's much less government intervention. We, of course, in Canada have universal healthcare coverage, but we don't have coverage for medications to the same degree. We don't have dental coverage to the same degree. We don't have the same blanket of support for the citizens. It provides less support than the Scandinavian countries. So these are the two ends of the spectrum in terms of high-income countries and their approach to welfare states. There's some in the middle, so-called conservative and Latin welfare states, which are seen in other parts of Europe as well. So poverty and health. So poverty imposes significant individual and societal health costs. It's just as some examples. It's the primary determinant of children's intellectual, emotional, and social development. It's a predictor of virtually every adult disease known to medicine: diabetes, heart disease, stroke, arthritis, some cancers. It predicts some non-medical conditions, social exclusions, deprivation, lack of access to the opportunities to thrive. It's a critical social determinant of health, both for communicable as well as non-communicable diseases. And practically speaking, what it means is that it increases predisposition to disease. It delays the diagnosis of disease or impedes the accurate diagnosis of diseases. And then it impedes the optimal management of disease. It therefore influences these multiple health outcomes, as mentioned. Some of these examples include the ability to pay for medications, which then influences health outcomes. It impacts transportation, if in this case, not just within urban centers, but especially in the divide between rural and urban centers. People who live in rural areas have much more challenges with transportation to get to where they need help, and poverty just complicates that. It contributes to higher rates of loneliness, contributes to high use of emergency department visits. It impacts health literacy. And the relationship between poverty and CKD is a bidirectional one. I mean, in terms of poverty causing CKD, there's some evidence that it's a direct cause. For example, as mentioned earlier, mothers who are experiencing malnutrition will have or are at risk for low birth weight children, which is an independent risk factor for subsequent kidney disease because they tend to be born with low nephron mass. And then there are indirect links to poverty-associated risk factors, which include higher rates of diabetes and hypertension in poorer countries directly as a result of poverty. And then the other way around works as well. The presence of CKD, the requirement for management of CKD can increase risk for poverty. There's a term I came across in readying for this talk, financial toxicity, and it has to do with the proportion of a person or household income that is directly attributable or going directly to healthcare costs. It grows and grows and grows, and at some point it becomes toxic. People are not able to take care of their other needs because that increasing proportion of their income goes towards healthcare costs, and they're not able to work as well. So I'll skip this, but this was just showing that this is a worldwide issue. It's not just in Canada. The financial toxicity impacts multiple people worldwide in high-income countries and in low-income countries and in between. And to focus a little on Canadians and their risk for kidney-related healthcare costs. This was based on a survey. The majority of patients in the survey were receiving in-center hemodialysis, which is similar. This is actually quite representative of what we see in Scarborough and what's seen nationwide. The majority receive in-center hemodialysis. Less than 20% receive PD, and a much smaller proportion yet go on to dialysis, to transplant. And so since starting dialysis, the majority, I think it's 70%, observe a decrease in their income. And an income decrease of 50% or more is seen in about a third of people who are on dialysis. The breakdown is there on the right. Only 25% stay the same. 5% actually do better, which I think has nothing to do with CKD, or this must have other factors. And what this means, this decrease in income, is in some cases, especially if they're below the low income level, missed food, missed basic necessities, missed ability to purchase medications, missed dialysis appointments, missed doctor's appointments. Those who are below the lower income have more of each of these unfortunate outcomes. And when you look at it by household income and you look at how their type of dialysis might differ, you can see that the in-center dialysis, the bottom graph, which has in blue, in-center dialysis, it's higher in low-income households. And as income goes up, the proportion of the home-based therapies, the PD and the home hemo, goes up relative to the home in-center dialysis. So in other words, the poor, for a variety of reasons, are less likely to have a home-based modality, and are much more likely to receive in-center, or much more dependent on a center, an in-hospital or in-facility center for their dialysis. So what about in Scarborough? And I'm going to present a little bit of work that I've done in this area, but I want to start off with saying that this type of information, particularly the information about risk for poverty, is not routinely collected. I've talked with some of the social workers, and we'll talk more about it, but it is not routinely collected at our hospitals. So in the context then of a study, I looked at two cohorts, all of our patients who received dialysis between 2016 and 2019 over a 4-year period, the end of 2019. And I looked at those that had information those that were based in Scarborough. So they had to have Scarborough area codes, and I came up with a cohort of 1,116 patients, and I was able to obtain their ethnicity and their birth country data as part of this cohort. And then there's a pre-dialysis cohort that we had been following in the corporate drive office for about a 3-year per patient period. It was an observational cohort study. And we looked at 1,600 of them, and again, tried to get information on ethnicity and birth country, and ended up with 1,280 in this non-dialysis cohort. And so we then looked at their risk for risk for poverty at the area code level. So there is something called the material resources or the marginal resources score, a validated means to predict someone's risk for poverty. And those who are in the 5th quintile are in the bottom 20th percentile of income, education, household stability, a whole bunch of bad metrics. They're in the bottom 20th percentile. And I looked at our patients in Scarborough, our dialysis patients. This is the first cohort, according to where they were from and also according to their ethnicity. And you can see that among immigrants, for example, there were 386 immigrants who were in that dialysis cohort. 44% of them were in the bottom 20th percentile. 44% were at the highest risk for poverty, as opposed to 39% of people who were not immigrants. And by region of the world where they came from, they were all pretty poorly off, right? They were 46%, 42%. So this shows that, or confirms that people who are on dialysis, as a rule, are at high risk for poverty. When we looked at it by pre-dialysis, the other cohort, before they've been committed to dialysis and while they can still work and while they're still maybe feeling better, the rates between the groups was a little more striking. So, for example, among ethnic groups, Black people, 39% of them were experiencing poverty, whereas among whites, only 19% were experiencing poverty. And by region of the world, those who were from Europe, 20%, whereas those from the Caribbean and South Asia had higher rates. So, and immigrants, 29%, non-immigrants, 19%. So that told me that what was seen at the national level was seen at the local level, but there was some nuances in that there were differences by ethnicity and by country of birth. So what to do about the risk for CKD? I think earlier detection is key, both at home and broadly worldwide. Optimal treatment to delay or prevent progression stands to reason. It makes sense, and this is impeded by the lack of access to treatment or medications that delay progression. A sensible and sensitive treatment of ESRD, it doesn't really make sense to do in-center hemodialysis in largely rural populations or in very, very poor countries where it makes more sense financially to invest in home-based therapies like PD. Research and quality improvement initiatives to reduce the equity that we see in CKD, that we have even seen, that we see even here in Scarborough. More needs to be done to kind of level the playing field here. And so what about the poverty risks? Again, this is not my wheelhouse, straight from the reviews, but a more detailed analysis of the economic, political, and social barriers to the implementation of public policies to address poverty is indicated. Advocacy focused on the individual social determinants of health and on poverty reducing policies is needed. We need to do more research into poverty and its effects on health, on development, and the ability to reach potential, and the impact on quality of life. And we need more information, I think, from patients, the lived experience of poverty and from their perspective, barriers to accessing healthcare. So the advocacy options, the poverty reduction advocacy options include these three things. This is from my reading. Reshaping services, so new or improved healthcare systems, social service, justice, police, etc. The goal here being to make poverty more bearable. So we're not going to improve your living conditions, but we're going to try and help you cope with your adverse living conditions, versus reducing the setting that then predisposes to the challenges of poverty, provision of universal health, childcare, more health and social services like medications, entitlements that are maybe merit-based, based on your income. So that's another broad strategy. And then the third one is just doing the Scandinavian approach, throwing way more money at people at the social fabric level, increasing living wages, social assistance, disability benefits across the board to try and make it so that not 15% of the people have experiencing poverty, but closer to 5% of the poverty. This is something that is quite far from what we do right now. And then when it comes to CKD reduction options, specifically, there's the importance of easing the costs of transportation, food, and medications for our patients who are experiencing poverty, especially. There's the idea of promoting home dialysis and transplant through incentives, through making it easier, like reimbursement of utility costs, increasing health literacy, patient and family awareness to make advocacy, basically to allow them to have more at home or closer to home dialysis. And then I think another important thing is better routine data collection, including measuring financial health of our patients, measuring their health literacy, understanding the disparities that we're seeing, including in places like Scarborough. What is it about certain ethnic groups, or particularly what I found, certain immigrant groups? Why is it that we're seeing these disparities? And the only way to kind of answer this is to get better routine data collection that's done across the board. It would allow us to understand and then therefore maybe make a difference in terms of these disparities. So currently what is being done, here I have to put a shout out to our social workers. They're and the patients' unsung heroes in this department. They are, particularly at our hospital, unfortunately, there's a bit of an ad hoc approach. It's usually triggered by patients, goes to the renal social workers, who then will look at the patients and send an application to the relevant funding agency or the relevant insurance agency. So, for example, based on their age, they might get an application to the ODSB or to Trillium, or based on household, depending on household income, they might help them with applying for disability credits, which really only applies if people are on dialysis. And when it does, the amount that's given still puts them at a very disadvantaged level. So it's meager, even if they do get government social assistance. Here's a homegrown tool that I wanted to share with you. It's something that I came up with this summer, coming out of the cohort study that I presented earlier. Those patients that were followed for the 4 years that were receiving dialysis, I had their postal code. That's how I was able to get their area code risk for poverty. And I have all this other information you can see here, where they're on hemo, where they're on PD, home hemo, their ethnicity, immigration status. And the idea behind developing this tool was to map out the provision of services relative to where the patients live. And it's by area from where they live, area from the center of the dialysis to where they live. And it's color coded. So 5, 10, 20, or 50 kilometers or more from the dialysis center. So here's an example. If you pick the center as Centenary, This is Centenary on the map. This is the Rouge Valley. You can see right off the bat that Centenary is in a lot of green space. Kind of explains why there's a lot of trouble finding parking at Centenary. But if you make this the epicenter, dialysis center, and then map out all the patients that we had dialyzed between 2016 and the end of 2019, you can see that there's significant eccentricity uh, to their location relative to the dialysis center. I took out those that are 5 kilometers or less from the epicenter, and you can see that there are so many more that are to the west and to the north and south than there are to the right, to the east. And along the DVP, you can see these are people who have to go 20 kilometers or more to the dialysis center. There are quite a few of them. And if you look at you can filter it. And here, so those who are experiencing or high risk for poverty, they're in the 5th quintile. It disadvantages a lot of them. These who are in yellow are experiencing or a very high risk for poverty, and they have to travel 20 kilometers or more to get to this particular dialysis center. So the idea behind, and you can do the same for whatever filter you pick here. So for immigrants who, as you know, are at risk for poverty, especially recent immigrants, similarly, there's not a bullseye kind of distribution relative to this particular dialysis center. And this tool I thought could be used to then find an optimal center. So here, this spot I picked, which is near the Scarborough Town Center, Brimley and Ellesmere intersection, looks a lot more bullseye-ish, even from the perspective of people who are experiencing poverty. So I think something like this might help, where the idea being that the provision of resources should take into account where people live, how much they have to travel, their transportation needs, and beyond that, their risk, their experiences of poverty. So in summary, CKD and poverty are growing problems, both worldwide and here in Scarborough. There is a significant bidirectional link between CKD and poverty. The current universal healthcare system and the standard biomedical model of care fall woefully short of addressing the interaction between poverty and CKD. And to address them, I think multi-level solutions are needed, both to address them individually and their interaction. And they can be from small things like this thing that I did, and I think we can all do things at grassroots level, and then all the way to the top where we are beating the drums outside Queen's Park or outside Ottawa to advocate for policy changes that can help with these problems. So with that, I think I'm done. I'm happy to take questions.
Tavo, quick question. When patients go for their dialysis, how long is their session in general? How long are they on the machine for hemo?
Most are on for 4 hours.
So with that map that you show and how far they're out, and if they're taking public transport, that's pretty much their entire day.
Exactly.
So again, I think it sort of demonstrates the challenges to these individuals, especially in terms of being able to work and again, sort of the relationship that you sort of outlined. Um, in terms of the data that you showed in terms of our population of patients in that MR category of poverty, um, do we know the rapidity of progression? Like, yeah, I think you've demonstrated that our region and the population that we serve, there is a lot of individuals uh, affected by poverty. Um, are we demonstrating or showing that patients are then progressing quicker to needing dialysis because of poor management of the other comorbidities?
Well, because we don't routinely collect these data, we don't know. So we don't have a system in place to measure these important risk factors for poverty, for kidney disease, progression. Um, so the answer is we don't know. It has been reported elsewhere, and I think we're unique and therefore worthy of being studied locally, preferably by ourselves. Um, but elsewhere, there is a clear link, an increase in the risk for poverty as you go along the continuum of CKD from stage 3 to dialysis dependence. But like I said, I think that's going to be modified by Scarborough specific factors. We have the world in Scarborough. We have so much more um, variety or diversity in Scarborough, and a lot of the people who would be at risk for kidney disease just from the basis of where they lived, like in parts of Africa, the Caribbean, uh, they presumably impact the rate of progression here. And in fact, this same study that I showed you parts of, we showed that like they are forming a disproportionate number of people, and the rates of progression were independent of the MR score. So the rate of progression of the decline in GFR or the rise in proteinuria rates were, when you put this into the model, they didn't, when you put their socioeconomic score as assessed by the MR score, uh, it was independent of that. So, but to me, that just says that that the poverty score may not have as huge a role in terms of the progression rate, although I think it does. It may be that it's on the other side. Once you get kidney disease and you're on end-stage dialysis, that's when you slip much faster. Like in other words, CKD affects poverty risk maybe more so than poverty affects CKD risk.
Tabo, George
Yes.
Vertes here. First of all, excellent presentation. I just wanted to highlight a couple of issues as well. I mean, the government always talked about pharmacare. And if you're between the age of 18 and 65 and you have some sort of medical illness, dealing with heart failure, dealing with heart disease and other issues, that will probably put you into the poverty level. And we know that good medical therapy will prevent hospitalizations, will prevent progression of heart disease, will improve quality of life. So the fact that, I mean, you focused on kidney disease, but certainly in the cardiology world, I mean, we see this all the time where patients who don't have third-party coverage, they're below the age of 65, they don't have public health coverage, and we give them half a dozen medications. I think we often forget that these patients are non-compliant, not because they don't want to take their medications or have side effects, but simply that they can't afford them. And so clearly we see deterioration of their conditions. I think in the United States, where many people are without health insurance, I think we probably see the same thing as what you highlighted for kidney disease. So I don't know whether the government is responsible for, should be implementing this pharmacare issue. I know that many different departments don't talk to each other, so that they may not cover a medication that we know has been effective and helpful, yet that falls under a different branch of the government, as opposed to funding for hospitals. And so we may end up saving money by giving medication, but they won't fund it. And yet it ends up costing the government more in the long run, like where patients are seen more frequently and don't end up in hospitals. So, I mean, what you've discussed is the tip of the iceberg for not just kidney disease, but for many other health conditions that our
sure.
patients are suffering with. One of the issues is even parking. So when you come to the hospital, you have to pay. I mean, we that patients won't come to a point for that.
I'm sorry, George. I don't know if it's you or me. I'm not, you're cutting out.
stress.
Yeah, again, I'm also having a hard time. I think Dr. Vertes, the internet might be a bit glitchy where you're at.
Okay. So, but I completely agree with what George was saying. I think it's just the tip of the iceberg, and a health economic approach that doesn't have or deal with silos, but it's like across the system. It just stands to reason that the demonstration of cost effectiveness will result in an upstream out of hospital prevention, early detection approach to managing these chronic diseases. It's it just makes a lot of sense. I agree with you completely.
Thank you.
Tabo, I had a question, it's Grant here, about dialysis capacity. How is that determined, and is dialysis run on a catchment area basis? Because it seems like those people who are traveling a significant amount of time to travel, like that really impairs, any ability to, there. But it would strike me as it impairs their ability. It would have negatively impacted their poverty level, having to spend most of their time or their whole day, as Vince pointed out, just for the whole day is gone, really. Is it does it run on a catchment area, or like how does that work in terms of several patients on that map like are coming from fairly far out?
Yeah, well, some of them, I gotta say, were like visiting. Like this was everybody that received dialysis. So I think there was one from Alberta, for example. They were just visiting during that observation period. But most of them are chronic long-term dialysis patients, and the factors that dictate where they go are multiple. And all the centers, the dialysis centers, experience this. They have the local catchment area that you alluded to, population, but they also have issues to do with doctor-patient relationships. The patients like their or are attached to a doctor. The doctor may move, and so they move, or the center provides more socially or culturally sensitive care. So, for example, First Nations people, we have not that many because there is a culture of more sensitive care provided to them at St. Mike's. So the Scarborough dialysis patients who are of that ethnic background, we don't see many of them. They're all at St. Mike's. So that's like a cultural kind of, the Ashniwabi, I think it is the center downtown, which is not too far from St. Mike's. That's where they go. So it's all the centers see it, and it imposes, I think, a lot of not just for the patients, but I think it has to contribute to the gridlock that we see every day that we jump into when going to work or coming back from work. All the wheel trans people, going from North York to St. Mike's for dialysis, like it happens, and it's not ideal in my opinion. I get that people are attached to their physicians and their centers, but I think it's something which, if it could be intervened on in a appropriate way, would help with a lot of these issues with being closer to home, with ability to work, with traffic gridlock. I think there'll be a lot of benefits to efforts to try and have a more local provision of care.
Lastly, Tabo, what was the term that something toxicity? Was it
Financial toxicity.
financial toxicity? Okay. Another catchphrase that I'll try to use. But
I don't know what
as you mentioned again, I think a lot of the comments that were made sort of allude to that. Once patients are on dialysis or have these chronic illnesses and the costs of receiving care, medications, time spent to get to appointments, again, it sort of all leads to that. So.
What do you think about the idea of trying to standardize the collection of this information across the silos within our hospital, like, at entry into through admitting or through emerge, or all getting capturing everybody's risk for financial toxicity, for how much time do they spend, or these types of things, like not.
Yeah, again, I think it would be great, and I'd be interested in terms of how again, to me, it sounds like it was a lot of individual effort to try and get each individual's demographic details. Um, and if there was a easier way to do that, or once it's captured in Epic, hopefully it would stay there. But again, I think that, it's not just sort of a kidney related issue, and it's probably pertinent to all of the chronic illnesses that we see. And again, I think it would reflect more and sort of demonstrate the perhaps different population that Scarborough represents. So again, I think it would be a useful endeavor.
Mhm.
Again, thanks, Tabo, for the great rounds, and again, the data that you presented.
My pleasure.